I've got a whole lot of questions, but how do we tie this? We're tying this into ECMO, of course, and a lot of things you talked about during the discussion I'm going to bring up, especially as it relates to ECMO. But your next talk actually regarding phenylephrine, I guess you're going to tie it in towards the end, because when a patient is critically ill, and even in the operating room during standard bypass, we use a ton of Neo. I mean, we think of Neo like it's a baby aspirin sometimes. We don't really consider. So I'm going to be very interested in your next presentation and tie this into how we treat hypotension, what we should be doing, because these are really important questions, I think. So with that said, if you're ready, I'm ready.
Absolutely. Well, let me just say one thing, because I do an awful lot of ECMO now. We are on bypass. If you're on ECMO, we are on bypass.
If it's VA, VV maybe a little bit.
Right. Well, that's a lung support. But if you're VA in any way, we are on bypass. So when everything that I was just talking about, we're on bypass. You may be in the ICU and you may be running a little bit different pressures and a lot more drips, but you're on bypass. And all the things that apply to what we are perfusing or how we are perfusing apply. And the renal blood supply is important to that. So that's what I'm going to tie into now, and why I'm glad we're doing a part 2, because it's good to understand the renal blood supply and what happens with the kidney and why it's different. But what we're really going to try to do is, as perfusionists, is we try to deliver oxygen. You can circulate blood around all you want, but if there's no oxygen in it, we're not doing any good, right? So we're going to talk now about the delivery of oxygen, and keeping in mind what we just talked about with the kidneys. Well, I'll try to answer these questions in this presentation, which is, what is delivery of oxygen? How is it determined? How much is adequate? How do we monitor it? How do we know it's even being delivered? And is it even going to make a difference? And as I talked in the previous lecture, now hopefully you understand why we might regard the kidneys different from any other organ. Well, so what is delivery of oxygen? DO2 is usually with a symbol that's used, and defined as, oxygen delivery is defined as the amount of oxygen delivered to the tissues or to the capillaries per minute. Well, how is it determined? Well, it has to be calculated. And a lot of you have seen this formula before, but delivery of oxygen is the blood flow times the oxygen content of the blood. So you have the amount of oxygen that's in the blood and at what rate you're delivering it, right? So it's Q, which is a symbol for blood flow, and the oxygen content of the blood is made up of 2 components. It's that which is attached to the hemoglobin, known as oxyhemoglobin, and the oxygen that's dissolved in the plasma. And as most of you know, the oxygen that's attached to the hemoglobin accounts for 97% of the oxygen carrying of the blood, the oxygen content of the blood. And there is another small component, 3% of it dissolved in the plasma. So the final is DO2 equals Q, which is blood flow, and the formula for the oxyhemoglobin part is 1.36 times hemoglobin times the saturation plus 0.031 fudge factor times the partial pressure of oxygen. And there's a conversion factor of 10 at the end to make the units work out, okay? That's what that is. But what we really want to talk about is the delivery of oxygen index. Okay? It's the same formula divided by the body surface area. But the easy way to look at that is, instead of using blood flow or cardiac output, use cardiac index in that spot. And then you get an actual delivery of oxygen index, which is more important because that way we're delivering it per tissue weight. So how much is adequate? Well, let's look at a normal adult at rest. The delivery of oxygen index ranges between 450 and 800 milliliters of oxygen per minute per meter squared. I'll show this to you. So if you use normal adult at-rest parameters, let's just say the range of cardiac index for an adult at rest is somewhere between 2.6 and 4.2. Hemoglobin would be somewhere between 14 and 18. Saturation would be 90 to 95, and PO2 maybe somewhere between 85 and 90. So let's pick some reasonable numbers. Let's say our cardiac index is 3.5, hemoglobin is 16, 95% saturation, and a 90 PO2. And if you multiply that out, it tells you that most people are probably around 700, 733 milliliters of oxygen per minute per meter squared being delivered. So that verifies the range that I show you at the top, that most people are somewhere within that range. And I can tell you that Most people are probably more in the 700 range, more than the 450. Well, what is the typical delivery of oxygen index that we normally do on bypass? Well, here's some examples of a calculation example of what we normally do. So most of us are flowing a cardiac index of somewhere between 1.8 and 2.6. A hemoglobin on pump would be between 7 and 10. Saturation is going to be 97 to 100%. And PO2, most people are probably somewhere between 150 and 450. So let's pick some reasonable numbers here as well. Let's say you're flowing 2.2 index, your hemoglobin's 8.5, you have a 99% saturation, and your PO2 is 300. Well, that gives you a delivery of oxygen index on bypass of 272. Pretty big difference from the 733 that we just used. So if you compare the two, normal range on pump, and if you plugged in various different numbers there that I have on the ranges, you'd come up with a low of about 180 and a high of about 380 versus the normal adult at rest range of 450 to 800. So we typically provide about 35% of the delivery of oxygen index at rest on pump comparatively, okay? How do we monitor it? Well, there is no continuous monitoring available. There is no probe and a device that you can connect to your arterial line that'll give you constant real-time delivery of oxygen that you're providing. And therein lies a need and a problem. And so it has to be calculated. Well, I don't know too many of us that are sitting there and every 3 to 4 minutes doing a calculation to see if our delivery of oxygen is adequate. Well, because first of all, do we even know what is adequate? And if we did know what was adequate, how do we know it's being delivered? Well, this is where some research has come in, and it's closing in on some answers. Here's 4 articles. I'm going to talk about each one of them listed there, where they look at specifically to delivery of oxygen to the patient on bypass. So let's look at the first one. And this was McGruder. He's done a lot of research into this topic. Journal of Thoracic Cardiovascular Surgery, 2017. He took 172 cardiac surgery patients and they were a 1-to-1 propensity matching score. In other words, they matched identically for risk factors. He had a control group of 88 patients and a goal-directed group of 88 patients. The control group was perfused at a delivery of oxygen index of 240. And the goal-directed group, he purposely perfused at a higher rate, and they targeted 300, and they ended up at an average of 302 on those 88 patients. The control group ended up averaging an increased creatinine level, 22% increase in creatinine, and they had a post-op AKI incidence of 24%, where the goal-directed group only average creatinine spiked 9%, and they had a post-op AKI incident of only 9%. Pretty dramatic decrease. Well, this is really by most people's standards who look at this, acute kidney injury with respect to delivery of oxygen. This is kind of the gold standard paper. Dr. Renau's done a lot of this. He's out of Italy. Annals of Thoracic Surgery, 2005. He looked at 1,048 cardiac surgery patients. And they were trying to identify the delivery of oxygen in relation to acute kidney injury. And he was looking to find where is the cutoff value that we need to be above to reduce acute kidney injury. So he looked and he discovered a cutoff value at 272 milliliters of oxygen per minute of cardiac index. And below this amount, patients had a 2 to 6-fold increase in acute renal failure with a D2 delivery of oxygen below this threshold. Anybody who was perfused below 272 had a significantly higher increase in acute injury and a significantly higher mortality rate, 11% versus 1.7% of everyone who was perfused above that. This is considered where we believe the cutoff should be somewhere around 270. Dr. DeSommer and his group, and this is in Critical Care Medicine 2011, looked at the same thing, and they took 359 patients. They looked at delivery of oxygen, but they also looked at carbon dioxide production to see if there was some indications there and correlations. And again, they discovered very close to Dr. Renau's, the previous slide, they identified a threshold of about 262 index. And they discovered that patients that were perfused below this threshold had a 23% incidence of AKI. And patients that were above this threshold had only a 7.4 incidence of AKI with predictive accuracy value of 92.5%. McGruder, he did 170 cardiac surgery patients, published his reports in the Annals of Thoracic Surgery 2015. And they looked through their several thousand cases that they had done, and they wanted to find a perfect one-to-one propensity matching score. And they discovered 85 patients who matched perfectly with another 85 patients, but the first 85 patients did not develop any AKI at all, total non-AKI group. And they found 85 control patients that matched with the risk factors of the first, of who did develop AKI. So 85 non-AKI patients matched with 85 AKI. They discovered that the non-AKI group had a delivered oxygen index was always above 230. The AKI group averaged delivered oxygen index of about 208. If you look there on the non-AKI group, the 30-day mortality of the group that had no AKI was only 5.9%. The 30-day mortality of the AKI group was 35.3%. And incidentally, I put on there the amount of average amount of phenylephrine that was used. And in all of these studies, when they perfuse the patients at a higher index, they end up having to use less of a vasoconstrictor. So the bottom line was he found a result of 230 as a cutoff for the development of AKI in cardiac surgery. So now I want to talk about our role as perfusionists and what we can do in bypass and maybe what we are doing. And I want to specifically look at the role of phenylephrine because, Joe, as you were saying in the break, if you've been doing this as long as you and I have, you remember back in the 80s and 90s where we just didn't have phenylephrine on the pump. We just didn't have it. It wasn't in our toolbox. I remember doing 200 to 300 cases a year, and I don't think I used phenylephrine once or twice the entire year. We were running blood pressures between 50 and 70, and you just don't really need phenylephrine to be in that range, right? So let's take a look at what maybe has happened here. Well, this is all from the package insert, and phenylephrine, basically what it is, it's an alpha-1 adrenergic receptor antagonist, right? It's an alpha-1 vasoconstrictor. It's used for increasing blood pressure in adults with hypotension resulting primarily from vasodilatation. And primarily, it's supposed to be used in septic shock or in cases of anesthesia. So, phenylephrine, what did we know and when did we know it? I say that because this was patented in 1927 but came into use back in 1938. This is not a drug that's new and we're still learning about. This is a drug that's been around an awful long time. Now, I looked into the prescribing information. This is directly from the manufacturer's insert that comes inside the box when you take a Nephron out in the morning. This is your package insert. And I took excerpts from this package insert. It's very interesting what I found. Under warnings and precautions, number 1, under peripheral and visceral ischemia, the manufacturer says phenylephrine can cause excessive visceral vasoconstriction and ischemia to the vital organs. Number 2, under warnings and precautions, under the subheading of renal toxicity, the manufacturer says phenylephrine can increase the need for renal replacement therapy in patients with septic shock. Monitor renal function. Now let me just go back real quick. It can cause renal replacement in patients with septic shock. The purpose of it was to be used in septic shock. But yet they warn you that this is one of the cases where it can cause renal failure. So number 3, under geriatrics, this is very interesting. When they researched and did the FDA approval on phenylephrine, clinical studies did not include sufficient numbers of subjects aged 65 and over. Do any of us do patients over 65? They did not do enough patients over 65 to determine whether they respond differently from younger subjects. Dose selection for elderly patients should be cautious, reflecting greater frequency of hepatic, renal, and cardiac function. This is right off the package insert. Number 4, under specified populations, renal impairment. In patients with end-stage renal disease, dose response data indicated increased responsiveness to phenylephrine. Consider starting at the lower end of the recommended dose range and adjusting. So in other words, they already know that phenylephrine is very sensitive to renal vasoconstriction. So in cases of end-stage renal disease, they're cautioning you to be even more careful. It goes on. There's number 5, the pharmacodynamics. The manufacturer states phenylephrine has activity on most vascular beds. Well, they could have stopped the sentence right there because we know that it's an alpha-1 vasoconstrictor. But they go ahead and including renal, pulmonary, and splanchnic arteries. So the manufacturer felt compelled to include that in this statement. And the 6th thing, under pharmacokinetics, following an intravenous infusion of phenylephrine, the observed effective half-life was approximately 5 minutes. But the observed plasma terminal elimination half-life is 2.5 hours. In other words, you may not see clinical effect, so your vasoconstriction and your use of it wears off very quickly, so you think that's the end of it. But this drug remains in the plasma for hours. So perhaps on a subclinical level, we're having more vasoconstriction that's not evident clinically than we know about. That's just something to look into. So back to what did we know and when did we know it? Well, the manufacturer has known this since 1927. But here's an interesting paper. Dr. Crosley and Clark in 1951, who had been using phenylephrine on their patients for hypotension, decided to write a little paper and do an experiment, and they published it in the Journal of Pharmacology and Experimental Therapeutics. And their abstract, they say phenylephrine is widely used for the restoration of blood pressure, but it's frequently associated with renal impairment. In other words, this is what they were noticing. They would give their patients this new blood pressure medication. They noticed that they were having an awful high incidence of renal impairment. So they decided to do a little study. And so they said, we sought to determine if phenylephrine has a constricting action on the vascular bed of the human kidney. So they just took 5 normal-tensive adult patients, sat them down in their office one day. They were normal, healthy adults. And they gave them 5 milligram dose over 30 minutes. 3 of them they gave an IV, and 2 of them they gave an IM injection. And what was the result? The result was all patients had a decreased renal blood flow. And here's our conclusion. And this is important. The significant reduction of renal blood flow associated with an increase in systemic blood pressure indicates an increase in renal vascular resistance greater than that of the body as a whole. So this is what's important. If you have an alpha-1 vasoconstrictor and it vasoconstricts equally everywhere throughout the body, then the blood flow is going to distribute itself equally as well. And this is what's important to know, that it's actually more powerful in the renal vasculature. Therefore, blood's going to follow the path of least resistance, and you're going to get a decreased blood supply to the kidneys. So Dr. Clark, although they only did 5 patients, it's just kind of a red flag way back in 1951 that they're just kind of waving and saying, hey, look, we've looked into this, and it's a very small study, and this is what we find. So this is what you need to know. This is a take-home slide right here. Phenylephrine's renal vasoconstrictive action. As I mentioned in the first segment, the afferent arteriole is what leads blood into the glomerulus, right? Phenylephrine's vasoconstriction occurs on the right side of the screen, right at the afferent artery. That is the worst possible place because you now decrease blood supply to the glomerulus, you decrease your urine output, and remember, the efferent artery, which has to go on downstream and perfuse the tissues, is going to have far less blood supply going out of that. Now, here's an interesting case report. This came out of Japan in 2003, Journal of Medical Investigation. And Dr. Shimoya and his group had a very unusual case where they were treating a 20-day-old infant who was undergoing a fundus examination. That's an eye examination of the microvasculature behind the retina. They gave the patient eye drops of phenylephrine during the exam, as they normally would. And the blood concentration, this is a quote from their conclusion, the blood concentration of the drug was elevated sufficiently to contract the renal vessels, ultimately inducing renal failure. They induced renal failure on a 29-year-old infant by giving him eye drops of phenylephrine. So now let's look at some more case studies. Here is Dr. Legrand in 2013 in Anesthesiology magazine. A quote from this article says, phenylephrine is often infused in complex surgeries with reported deleterious effects. This is the same thing Dr. Clark said in 1951, that they're using it and they see a common path repeating itself. where acute kidney injury, as well as the development of lactic acidosis. And all of you know, if you develop lactic acidosis, it's a sure sign of poor perfusion. So in the anesthesia journals, there's a lot of work that's been done on what's the best alpha-1 vasoconstrictor or vasoconstrictor in general to use during general surgery and all the patients that they do. Now, these are not bypass patients, but they often want to keep the blood pressure up in sedated patients. And these are 3 articles at the bottom. You can research them yourself. And a lot of these articles basically state the same thing, and they're referenced there at the top. Here it says here, they're comparing phenylephrine with norepinephrine. Phenylephrine infusion resulted in significant increase in splanchnic oxygen extraction. Well, if your oxygen extraction is up, that means you're not perfusing enough, and the tissues have to extract more, right? Phenylephrine infusion was associated with a significant increase in lactate concentration not found with norepinephrine. Phenylephrine infusion resulted in more pronounced global splanchnic vasoconstriction than with norepi. So, why have so many become so focused on blood pressure during cardiopulmonary bypass? And I think there's something that's probably happened in the last 10 or 20 years. But in the last 20 years, the reason is there's been a number of very influential studies that have come out, primarily published in the thoracic journals where the surgeons have really caught wind of these, indicating a direct relationship between hypotension and post-op AKI. So is that case closed? Low blood pressure, we need to run a higher blood pressure on pump. That's the cause of the AKI or a big contributing factor. Well, let's take a closer look. So Dr. Azo in Perfusion Magazine 2014 did a study where he was looking at increasing arterial pressure, whether or not it reduces the rate of acute kidney injury. And they took 300 patients, propensity score matched 1-to-1, and they did 147 of them under what they called a high pressure group where they perfused the patients in a high pressure range of 75 to 85. Then they had their low pressure group where they perfused patients, 145 patients between 55 and 65. But they maintained blood pressure with norepinephrine. Their conclusion, the rate of AKI did not differ by group. It was exactly the same, 17% versus 70%. And their conclusion was maintaining a high MAP during normothermic bypass does not reduce the risk of postoperative AKI. Let's look at Dr. Reddick's study. This was in Anesthesiology, Journal of Cardiothoracic Anesthesiology, 2017. And their aim in the study was, again, to look at post-op AKI attributed to hypotension. Now, they did 1,900 patients, 1,891 to be exact, over a 4-year period, 2011 to 2014. And what they discovered, there was a threshold of blood pressure only below 50 millimeters of mercury. They found, so the results were there was univariable analysis in patients undergoing isolated CABG. Intraoperative hypertension on bypass was not associated with an increased risk of AKI above a threshold of 50. In other words, their patients who maintained a pressure above 50 all had the same rate of AKI. It was only below that they saw AKI increase. Let's look at Dr. Cervantes' paper. This is in Perfusion 2012. Now, they were trying to find the sweet spot. They said if there is a pressure range that's better than all the rest, we want to find it. So they took 122 patients, and all these patients were over the age of 70. So they really wanted to try it in the elderly. And they segmented out 3 patient groups. A low pressure group, they perfused between 50 and 60. A mid pressure group, which was 60 to 69. And a high pressure group, which their perfusion was 70 and higher. What did they find? No differences in renal function through post-op day 3. Their urine output was the same. Their serum creatinine was the same. Their use and need for diuretics was the same. Their ICU stay was the same. And their length of stay overall in the hospital was all the same. So what are we to make of all this? And I can tell you there are numerous conflicting papers regarding hypotension on bypass and AKI. There's a lot of papers claiming low blood pressure is causing AKI. But let's look at blood pressure. Blood pressure is a completely dependent variable. It depends upon flow and resistance. Pressure equals flow times resistance, right? You all know that. You cannot adjust pressure. You can only adjust flow or resistance, right? We have no pressure knob on our pump, but we do have a flow knob, and we are able to adjust the resistance through pharmaceuticals. So pressure is a completely dependent variable, and blood pressure is not part of the delivery of oxygen equation, which I was talking about earlier. Delivery of oxygen depends on blood flow, hemoglobin, saturation, and partial pressure of oxygen. Nowhere in there is there a blood pressure. So what's the take-home message so far on delivery of oxygen? Any research that attempts to find a relationship between blood pressure or hemoglobin levels and AKI is in reality an attempt to address renal delivery of oxygen. At a high or low blood pressure or hemoglobin is relevant only as it relates to a corresponding renal blood flow and oxygen saturation, and hence again, the renal delivery of oxygen. That's why I think you have conflicting papers. If you're running a high blood pressure and it's because of flow, then your delivery of oxygen is adequate. If you're running a high blood pressure and it's because of vasoconstriction, you're not delivering oxygen to the kidneys. So that's really the target. So now let's go back full circle to the beginning of the first lecture and look at these AKI risk factors, reevaluate them, now that we can keep in mind these 4 things that we've learned. Renal medulla exists in a borderline state of hypoxia. Increased oxygen delivery to the kidneys results in a proportional increase in oxygen demand. The kidneys have a high demand for oxygen due to their enormous production of new ATP, and it's the delivery of oxygen to the kidneys that's most critical. So let's remind ourselves again, what are the variables involved in delivering oxygen? Blood flow, hemoglobin, oxygen saturation, and partial pressure of oxygen. Now, here's our preoperative AKI risk factors, same slide I showed in the first lecture. And I highlighted in red what I believe, and you could make an argument for more than this, have one or more of these elements of delivery of oxygen factors in them. Anemia, low hemoglobin, advanced age, restrictive vasculature, decreased blood flow, left main disease, poor cardiac output, hypertension, causes renal damage and vasoconstriction, COPD, poor oxygenation, peripheral vascular disease, vasoconstriction, balloon pump, embolus, stroke, embolus, history of smoking, poor oxygenation, poor LV dysfunction, poor blood flow. Meds that alter renal autoregulation, by the way, your ACE inhibitors, your ARBs, and your NSAIDs all cause the autoregulation of the kidneys to be disrupted. So those also have disrupting the blood flow and hence the delivery of oxygen to the kidneys. You can make an argument for some of these other ones. Look at the perioperative ones, though. This is where we come in. All except maybe one of these have one or more factors in delivery of oxygen. If you have a valvular complex case, that's a long pump run. Plus, as you know, in valve cases, you're likely to have embolus of air. Emergency operations, patients are not prepped well, maybe come in anemic. Reoperations are going to be longer. We've always known about perhaps non-pulsatility of bypass, which again results in blood flow. Any low flow perfusion state. Hypothermia bypass, by the way, causes renal vasoconstriction. Long pump runs, long cross-clamp times, anemic states, hemodilution, anemia, hemolysis, anemia. Red blood cell transfusions probably hit on all 4 of those. Embolism, alpha vasoconstrictors, I just talked about it. Anything that's going to congest venous congestion. Hypovolemia and going back on pump. So if you question that the delivery of oxygen is not important and plays a huge role in acute kidney injury, I think this slide. Now look at the postoperative risk factors. Now we're a little bit out of our league at this point, but when they go to the ICU, again, as I said before, if the patient gets poor hemodynamics, drops their blood pressure overnight, gets unstable, becomes hypovolemic, hypotensive, if they have to give a lot of neo or vasopressors in the ICU, if they have to put a balloon pump in, if they're going to give meds that alter renal blood flow, if the patient becomes unstable in the ICU, all of these have direct impact on delivery of oxygen. So my final comment on all this is that cardiac surgery is a clinical model for AKI. We live in the war zone because in this group of patients, we know postoperative AKI is going to occur, and therefore timely therapeutic interventions for prevention and treatment of early AKI could be developed as a field and as a cardiac surgery community. We really ought to focus on this because we live in the woods. This is happening all around us. In the conduct of bypass, it's really only prudent for us as perfusionists to improve the renal oxygen supply and demand relationship by continuously monitoring and augmenting renal delivery of oxygen to improve renal oxygenation. Thank you guys so much. Appreciate it.